Good evening, everyone. Welcome to SHEMAKERS Live. I'm really excited to have you to join me for another episode. On SHEMAKERS, we have conversations to help women develop their playbooks to win in business and life. I am Shavonna Williams, your hostess and the founder and CEO of Heelsand Helmets. I've worked in marketing and communications for more than 2 decades in corporate, politics, government, and sports, including 5 major sports leagues. Yes, I'm a veteran in this game. You can imagine I've been in several boardrooms where I was the only woman. I'm working to change that. My goal is to level the playing field, get more women in the boardroom at the head of the table with equal pay. What is a she-maker and why this show? A she-maker is anyone who is successful and talented and helps women succeed. Throughout my career, I've been fortunate enough to work and meet with some incredible women who are not only killing the game, but share my passion to help you succeed. Each week, I have one of these she-makers join me to have a conversation about a topic that's relevant to women, to learn and help give us strategies to navigate business, resources to hurdle the challenges we face, and inspiration to get moving on those wonderful ideas and get back up. You are a she-maker, and I am here to help you make big plays, get in the end zone, and win. Tonight, we have a very special she-maker coach. There's a lot of information out about pregnancy, and next month we'll be celebrating our mothers around the globe. But we don't have enough information about infertility. And it's something that a lot of women face, and they do not understand the options they have to still become mothers. Well, yesterday included this year's National Infertility Awareness Week. And I'm really excited to have our she-maker coach, Dr. Monica Bess, join us this evening to talk to us not just about infertility, but women's health. I know we've all seen a lot of posts about PCOS and endometriosis and know someone who has fibroids and has gone through that surgery or still faces the difficulties from the effects of having fibroids. But we're going to discuss all of that this evening. You've submitted your questions and we're going to get those answered for you. But while we're watching this show, I want you all to still feel comfortable to participate and share, but then also ask more questions. So I've set up a private text line that you'll be able to submit your questions anonymously. Now let's meet tonight's she-maker coach. Dr. Monica Bess is a reproductive endocrinologist and fertility specialist at Reproductive Biology Associates. Dr. Bess earned a Bachelor of Science degree in biology from the University of Michigan, where she graduated with honors and multiple academic awards. She is a native of St. Louis and returned to her home state for medical school, where she was awarded a full academic scholarship to attend the University of Missouri School of Medicine. It was during medical school that Dr. Bess became interested in reproductive medicine. She was awarded the prestigious Fulbright Scholarship, where she did research and later published work on the novel rapid non-genomic actions of sex steroids at the University of Pisa in Pisa, Italy. Dr. Bess completed her fellowship in reproductive endocrinology and infertility at the Emory University School of Medicine. Dr. Bess is not just a doctor for me. She is a friend. I am so happy to have Monica in my life and feel blessed to have her coach me and educate me on women's health. So, she-makers, thank you again for joining me this evening, and let's welcome tonight's she-maker coach, Dr. Bess.
I'm so excited.
Thank you again, Monica, for joining us. Welcome to the stadium and she-makers Live.
Thank you so much for having me. It's such a pleasure to be here this evening.
You are welcome. I know you've seen the show, but I have to tell you, I'm calling an audible on the way I usually conduct my conversations because we had a lot of interest in this conversation. And it's one of the reasons why I had to go ahead and make it an open recording. For our audience, you all know we usually do this live every Wednesday, but this is a really special conversation with Dr. Best's schedule, as you can imagine, between the pandemic and National Infertility Awareness Week. Just a ton going on. So I'm glad that we were still able to have the conversation, but needed to record it before Wednesday's public broadcasting. So thank you again, Dr. Best, and welcome everyone. Please drop a comment and share your enthusiasm for this conversation, and let Dr. Best know where you're watching from, and we'll get to your questions later. So, Dr. Best, I first want to get started by having you explain to us what endocrinology is. I think we're all familiar with what reproductive means, and we can understand what fertility specialist means, but what is endocrinology?
So endocrinology is really the study of how hormones in the body act on target organs to facilitate function. So really one of the focal hormonal systems that I deal with every day is essentially the interaction between the hormones produced from the brain to stimulate the ovaries to produce eggs. So, that is just one aspect of how endocrine hormones impact or function of different organs. So one other example would be thyroid hormone. Thyroid hormone is going to be released. It's going to act on the thyroid and tell the thyroid to produce thyroid hormone to enact its actions both on the thyroid and in other organs throughout the body. So, but primarily as a reproductive endocrinologist, we're really dealing with the endocrinology of both reproduction and pregnancy.
Awesome. Where did your interest in biology come from?
So, I've always been fascinated just by science in general, but, from a fairly early age, I had an interest in reproductive science. And really by high school, I knew that I had this interest in reproductive health and reproductive medicine and the cool science behind it. And I knew really by high school that I wanted to be a baby doctor. I wanted to be involved in this journey of helping women conceive and bring life into the world.
Were you a babysitter or anything growing up, Monica?
Not very often. I mean, this just really, I think, I was reflecting on this, earlier today, and that, this was just something that, I was drawn to and was cultivated. And so, no, I love kids, but I also enjoy building those relationships with my patients throughout all phases of reproductive life, but with that focus on pregnancy and helping bring life into the world.
You really got attracted to reproductive medicine while you were in medical school at Missouri. What were you learning or exposed to at that time that really ignited that interest?
Well, it was really the science and the research behind it. When I was in medical school, I was looking for research opportunities to become involved in research, and the reproductive endocrinologist came to speak to us in one of our med school classes, and I was absolutely fascinated by the embryology, the endocrinology of the science that they were really bringing to life as they talked about IVF and fertility treatments, and how we know key portions of the science to help us to be able to help couples that otherwise would not be able to conceive spontaneously on their own, achieve a pregnancy through this amazing science.
Now, can you go back a little bit? You said IVF. Can you explain what IVF is and how that is different from other treatments?
Yes. So IVF is an in vitro fertilization. So that's fertilizing an egg that has been collected from the ovary outside of the body with the male sperm. So, the actual fertilization, instead of happening in the fallopian tube where it generally happens naturally, this is happening outside of the body. So essentially what we're doing with IVF, a prerequisite is utilizing the same hormones that the brain utilizes naturally to stimulate the ovaries, by overwhelming the system with that, by having a female patient take injections of what's called FSH to stimulate the ovaries so that we can mature eggs in the ovary and harvest those eggs for the purposes of fertilizing those eggs outside of the body. Then the embryos that result from that process are grown in the lab, generally for a period of anywhere between 2 to 7 days before we would either freeze extra embryos or transfer embryos directly to the uterus. So, most of that process from fertilization to early growth of the embryo is happening in the lab or in vitro setting. It's not happening in the body. So that was fascinating to me. As a young medical student.
Can you talk to us about what are the biggest misconceptions that people have about women's health and specifically reproduction?
So I think, that's a loaded question, right? Because there are so many misconceptions out there. Mm-hmm. I think really, it starts with either a lack of information or misinformation really regarding ovarian physiology, like how many eggs do we have? How do those age? What does that mean in terms of our ability to conceive and not only get pregnant, but stay pregnant as we get older? I think that's one of the biggest misconceptions is you can come to somebody like me and it doesn't matter how old you are, you can, get pregnant with your own eggs. Now, there are so many different options in terms of how one builds their family. But what I want to do is empower women to understand, okay, this is what's happening with ovarian aging, and these are the things that we can do to mitigate that process or design a tailored plan whereby we're more likely to reach our reproductive goals and have children when we want to have them. So I think, just empowering women to understand how things work in terms of, ovarian aging, because I think people think that they can just come to someone like me and automatically have success. And I think, there are some things that we need to talk about as it relates to the fact that we're born with all of our eggs and those eggs age over time. And, there are things like fertility preservation we can do to help mitigate that or stop the aging process and be able to have eggs that we can use more efficiently. I think that's the biggest hurdle that we have is just, understanding how things work and how we are going to take action so that we meet our reproductive goals.
I agree. When I came to you, I was quite naive. I didn't think that there was anything to be done. I'm like, yes, I'm in my 40s, but I still have my period. My mother had my youngest sibling later in life. My grandmother had my mother, the youngest of 11 children, later in life. So what problems could there ever be? So there was a lot of education, and it was eye-opening for me to learn about everything that goes into reproduction, much more than we learned in, eighth grade.
Right. We need to revamp sex ed, don't we?
Totally. Well, you did talk about just ovarian reserve and also understanding that we get all of our eggs at one time. We're not going to be able to, fertilize and get more eggs. How can women protect or preserve their fertility?
Yeah. So the biggest driver of success and pregnancy naturally and also with fertility treatment is ovarian reserve, which is how many eggs you have and also what the quality of those eggs is. And so of course, as I mentioned before, we're born with all the eggs we're going to have, and over time as we get older we have fewer and fewer eggs as we approach menopause. Men are very different than us. Men are producing fresh sperm every 3 months of their lives. So the oldest sperm is 3 months old. And so, as we as women age, then there is some increased risk of chromosomal or genetic injury to the pool of eggs that we have that leads to an increasing rate of miscarriage over time. So as we get older, we have fewer eggs to work with, and making it harder for us to achieve a pregnancy. And then we have fewer quality eggs. And so that means that the older we are, the higher the risk is that we're going to generate a chromosomally abnormal egg. And if that egg is fertilized and implants, it's less likely to grow beyond the first 12 weeks and miscarry. And so we have a higher risk of miscarriage. And so really the best thing to do, especially if we know that we're going to be delaying childbearing, which many of us are delaying childbearing until our later 30s, whereas our parents were, getting pregnant in their 20s and early 30s. And so, as you can imagine, we start to see a much more rapid decline in ovarian reserve after age 35. So my recommendation is, if you know that you're going to be delaying, that you consider freezing your eggs, because if you freeze when you're younger, you're going to have more eggs to freeze and you're going to have better quality eggs. So you're going to be not only more efficient in terms of your pregnancy outcomes with those eggs, with that cohort of eggs, but you're also going to be financially more efficient, right? It's going to take fewer cycles, because you're going to have more eggs and more quality eggs available to you. And again, pregnancy rate's going to be driven by your age and how many eggs we have to work with. Okay, so I would consider fertility preservation in terms of being able to freeze eggs if you know that you're going to be delaying. Okay. Otherwise, there are other things that cause infertility, right? Even in young women. So, blocked tubes or, uterine fibroids that can interfere with implantation inside of the uterus. So again, understanding what's going on with your general health, avoiding sexually transmitted infections that can scar your fallopian tubes, things like that. Just understanding your health and taking good care of yourself are going to be factors that might ultimately contribute to infertility down the line if we're not paying attention to those things.
Well, based on what you just described, egg preservation will basically ensure that you have a healthy egg later in life. But there are other things we need to do to successfully carry a child, whether we're young or older. And we're seeing a number of women in their late 40s and 50s from, celebrities around the world start to have children later in life. In addition to the egg preservation, what steps do we need to take to delay having children to ensure successful carrying and then childbirth?
Yeah. So one of the things just to keep in mind is, we we know that there's about 15% of people with infertility in the United States. So that's a big number. Really, when you boil that down, you're looking at probably about 6 million people that unfortunately have infertility. And so what the goal is when you know that you're ready to have children, you've met the right partner, it's a good time, go ahead and get pregnant, because even fertility preservation isn't necessarily a guarantee for pregnancy in the future. What it does is it increases your efficiency later on in life if you are needing to delay. But the reality is the older we get, the more likely we are to have uterine fibroids or other medical conditions that may interfere or undermine our ability to carry a healthy pregnancy. And so, from my perspective, I know that there are options, right? I know that, even if someone comes to me and they have severe diminished ovarian reserve, they don't have a lot of good eggs or a lot of good quality eggs remaining, and the efficiency of treatment is not there because there is some attrition with the IVF process. Not every egg we collect is going to be mature. Not every mature egg fertilizes. Not every embryo will ultimately get to the point where it can be either transferred or frozen. And so, there are things such as egg donation that can help those patients. Also surrogacy, if the uterus is overtaken by fibroids or scarring from prior myomectomies where we've removed fibroids in the past, but then that has been replaced by scar tissue. So, my advice is when you're ready to get pregnant, when you're ready to start your family, go ahead and do it. Okay. Just because there are some things that are very difficult to mitigate. The first of which is ovarian aging. It's hard to get around beyond a certain age, just knowing that, for example, by the time we're 40, about 50% of the eggs that we have are going to be genetically abnormal. By the time we're, 45, we're looking at probably 80 to 90% of the eggs that we have are abnormal, and we have fewer of them by that time to work with. So, we really, I think the fertility preservation is the first and foremost, because, even if we have challenges with regard to the uterus, surrogacy is an option for you if you have eggs frozen to be able to create embryos. So, but for the most part, for most women, the biggest challenge is eggs. The uterus doesn't age in the same way that the eggs do. And so, even women well into their 50s, even if we know that their ovarian reserve is so diminished, we can't utilize their eggs. Oftentimes through egg donation, they can still carry as long as the uterus is normal. And we can oftentimes utilize the partner's sperm to generate embryos that are going to have a genetic link to the partner while the female partner is able to carry that pregnancy. So, I want to make sure people are empowered by the knowledge of the fertility preservation, because that's generally the biggest issue, not necessarily the uterus. And generally there's enough sperm to facilitate even assisted reproductive techniques. The issue is the eggs. Okay, that's the biggest piece of this.
Do we know exactly what causes infertility?
So infertility really, one of the things to understand is that, about 30% of infertility is related to female factors. So things like PCOS, where there is disruption between the communication between the brain and the ovary to make a mature egg each month. So those women aren't ovulating regularly. So therefore, if there's no mature egg available to be fertilized, how can you get pregnant? So there, about 30% are going to be female factors, anovulation, such as PCOS, tubal factor, where there are blocked tubes. Maybe you're somebody who has unfortunately had, a sexually transmitted infection like gonorrhea or chlamydia that scarred the tubes, or you have things like endometriosis, which is basically where there's inflammation and endometrial tissue outside of the uterus that can scar the fallopian tubes. You might also have diminished ovarian reserve or diminished number of eggs. That's sort of contributing to your infertility. So there are 30% are female factors kind of falling in that group. The other 30% are male factors, where there is a diminished amount of sperm, or there is an issue with the sperm actually getting out and being ejaculated. So that can be a male factor. Sometimes there are endocrine problems in males where there's difficulty in terms of generating sperm. So again, male factors, 30%. So 30% female, 30% male, and then 40% both. Okay, so some couples, have a hard time coming in because they're afraid it's going to be somebody's issue. And really 40% of the time, there's a factor that is resultant from both the male and the female that is contributing to overall infertility. And it's very often when I'll sit down with a couple and say, okay, well, we've got, one tube that's blocked, and also the sperm count is really low. So a combination of those factors is really frequently seen at the time of evaluation for infertility.
Okay, Monica, Dr. Best, I'm going to go to our questions to get you to answer some of the things that our audience would like to know.
All right.
The first question is, when you talk about egg quality, is that regarding the ability for the egg to attach and remain once fertilized?
So yeah, so there's egg number, which can be measured in terms of blood, can be evaluated with both blood work and ultrasound, where we scan through the ovaries and count the number of resting eggs on the ovary. But if I know your age, I can tell you exactly what the egg quality is, because for the average 35-year-olds, somewhere between 35 to 40% of the eggs that you have in your personal egg bank are going to be genetically abnormal, okay, because they've been around for 35 years. So the flip side of that is true too. If you're 35, probably around 60 to 65% of the eggs that you have are likely to be chromosomally normal. If those eggs are fertilized, then they're going to create chromosomally normal embryos. Those embryos, if they implant, more likely to go on and be a pregnancy. If eggs within that 35% are fertilized, they're more likely to generate chromosomally abnormal embryos and lead to miscarriage. So another way to think about this is, if you're 35 and you get pregnant, 35 to 40% of the time there's a miscarriage risk. 60 to 65% of the time, that pregnancy was resultant from a normal egg that was fertilized and is more likely to go on and be a beautiful pregnancy. Okay, so that's the way to think about egg number versus egg quality. Okay, egg quality is really what is the miscarriage risk that you have at a given age.
Thank you.
Mm-hmm.
Our next question is, what impact might lifestyle practices have on fertility?
So that's a really good question, because I would love to be able to offer some, cocktail that somehow preserved your eggs, prevented them from aging. But the reality is I can't stop ovarian aging. If I could come up with a cocktail for that, I would have made my contribution to reproductive medicine and I would be retired by now. But the reality is that ovarian aging is always happening in the background. So there's not anything that you're going to do to stop that from happening. But as I mentioned before, in terms of, things that can happen sort of outside of the egg, such as injury to tubes, from sexually transmitted infections. So again, wearing condoms to prevent acquisition of things like gonorrhea or chlamydia that are known to negatively impact the fallopian tubes by causing scarring. So, so some of my patients that are needing to do in vitro fertilization, where we're collecting eggs and fertilizing them outside of the body, have injury to their fallopian tubes, and natural conception is less likely to happen. So again, lifestyle things such as, protecting yourself by using condoms to avoid sexually transmitted infections is important. Also, we know that, when we carry around a little bit of extra weight, so higher BMIs have a slightly higher risk of miscarriage above their age-related expected risk of miscarriage. So trying to maintain a healthy weight, eating right, exercise, I think is always a good thing. We know that also there are some associations between increased miscarriage risk and caffeine intake, for example. So there's some data that suggests that if you consume more than 200 milligrams of caffeine a day, which is about a 12-ounce cup of coffee, you might have an increased risk of miscarriage. So I have my patients, back off on the caffeine when it's time to get pregnant, because that's the one thing we can control. Again, for most of my patients, that's not why they're not getting pregnant, but again, trying to optimize things in their lifestyle that create an environment that's going to be optimal for pregnancy. And we know that women who consume more than 500 milligrams of caffeine a day may have delayed time to conception as well. So all of these things, just taking care of your body, trying to maintain a healthy weight is important. And then, safe sex practices too is going to be important for protecting your tubes.
Okay, our next question. What advice would you give to women who have had fibroids who still hope to have children?
Well, the reality is fibroids are super common, right? Somewhere around 80% of African American women have fibroids. Probably 60% of women, Caucasian women, are going to have fibroids at some point in their lives. The question is where the fibroids are in relationship to the uterine cavity. Okay, so for me as an infertility specialist, one of the tests that we do is what we call a saline infusion ultrasound, where we place a catheter in the lower segment. We put salt water in to bring the walls of the uterus apart so that we can scrutinize the surface of the endometrium and identify where these fibroids are in relationship to the uterine cavity. So, if we identify that there are fibroids that are sitting inside of the cavity, then we need to talk about, surgery to remove those fibroids. And so I do not recommend things such as uterine fibroid embolizations, because it can cause, if you've got fibroids that are sitting in the cavity, it can cause that tissue to die and cause scarring inside of the cavity that is very challenging and oftentimes very difficult to get rid of. So I do recommend, in most of these cases, a surgical procedure, and then precautions to try to prevent scar tissue from forming where we remove that fibroid. Because it doesn't make any sense for us to take care of the fibroid and then have scar tissue form in place of that that's going to impede normal implantation. So, the first step is really seeing a fertility specialist, looking at the global picture, right? Because sometimes what fibroids can do is they can distort the anatomy and block the fallopian tubes as well. So how we approach getting pregnant, depending on the location of the fibroids or scarring that may have been left behind from a previous surgery, is going to really depend on a thorough evaluation where we know what's going on with the tubes, what's going on with the uterus, what's going on with the ovarian reserve, what's going on with the sperm, so that we can tailor our plan of how we're going to approach whatever challenges we have.
Okay. Are there natural options to treat PCOS other than birth control?
So this is, it depends on really what you're talking about. So, some patients with PCOS, what PCOS is an abnormal production of male hormones from the ovary. Now, all of us produce male hormones from our ovary. That's part of the hormonal production, natural, normal hormonal production from the ovary. However, women with PCOS create more male hormones from their ovary, which produces the symptoms. So, unwanted hair on your face, thinning hair on your head, hair on other parts of your body that you don't want to have, and also irregular menstrual cycles. So the elevated androgens are part of what creates that abnormal hormonal environment that prevents the brain from stimulating the ovary to produce a mature egg each month. So you're not ovulating. And so, really one of the most common things to do is to use birth control to regulate that. What birth control pills do, especially oral birth control pills, is they bind that testosterone so that those levels of testosterone go down. Again, you have less symptoms from hair growth, and we're also protecting your uterine lining from abnormal cells that can lead to endometrial cancer as well when you're on the birth control. So it's really difficult. There aren't really a whole lot of other treatments besides maybe giving you progesterone once a month to bring on a bleed so that you regulate those cycles. And then you don't necessarily have to use the birth control if you don't want. But sometimes giving a withdrawal bleed with progesterone to help make sure that we're protecting your uterine lining from abnormal cells that can lead to endometrial cancer is going to be important. There are other sort of natural supplements such as ovasitol that are very well tolerated in patients with PCOS that help to control some of the elevated insulin levels as well that can exist with PCOS. So what happens is the ovary produces male hormones or androgens, which then stimulates increased production of insulin. And then those elevated insulin levels feed back on the ovary, cause the ovary to crank out more androgens or male hormones. And so sometimes when you help with insulin resistance by helping to lower insulin levels, either with ovasitol, which is a natural supplement, or sometimes metformin is used, which is a medication often prescribed in diabetics to help lower those insulin levels, that can help also with some of the symptoms and help to treat PCOS.
It's a lot. Thank you.
Mm-hmm.
I've heard about PCOS really a lot over the last year. It was something that I had not heard of or been familiar with. So thank you for sharing those details.
Yes, and 10% of reproductive age women have it. So it's a very, very common endocrine abnormality that also, of course, affects fertility because of the inability to make a mature egg that's capable of being fertilized. So, a good portion of my infertility practice is made up of patients that unfortunately have PCOS and aren't able to conceive easily because they're not regularly making a mature egg each month.
Monica, are there symptoms that we should be aware of to advocate being evaluated for PCOS? It seems like it's something that a lot of people had for years, but were unaware, so they couldn't do anything to manage or treat it.
Yes. So, I think, for most people with PCOS, there's going to be a history of irregular or skip cycles since menarche. So when you talk to these patients, they'll say, I've never had regular cycles, or some of my patients with PCOS can go a full year without having a cycle. So a history where you're either having irregular or skipped cycles since the dawn of time when you first started having your periods, or those patients that have really long cycles, like it takes 50 days for their cycle to come. That would be sort of outside of the norm of what we would anticipate in terms of regular cycles. So those patients may have PCOS. Also, if you're somebody who's like, I've always just been really hairy, I have hair everywhere, or acne, or thinning hair, kind of in the crown of your head, kind of in a male pattern balding distribution. All of those things might trigger you to think, okay, maybe I should be evaluated to best understand, do I have PCOS? Because the implications are many, because again, its impact on fertility, also that increased risk for endometrial cancer if we aren't doing anything to protect the uterine lining. Because essentially what's happening is when you're skipping cycles or you're not ovulating, you're not shedding that lining. And again, you can build abnormal cells over time. Generally, these patients can develop, abnormal cells in the lining, and endometrial cancer is a real risk. So you really want to know what's going on. You really want to make sure that we're either giving that withdrawal bleed if you're not having regular cycles. Birth control, again, is a good way to protect the uterine lining and also mitigate some of those high androgen symptoms, because the birth control is essentially increasing proteins in your liver that allow for more binding of testosterone, so it's not acting on the hair follicle to increase hair growth or acne or balding.
Our next question is, in what ways have you witnessed endometriosis and consistently smoking marijuana affect fertility?
Yeah, so really there's a huge correlation between endometriosis and infertility and endometriosis. So patients with endometriosis are more likely to have a diminished number of eggs from what you would expect based on their age. And also the average infertility patient is more likely to have endometriosis. So there's a huge tie between that and infertility. Again, endometriosis is where there's endometrial tissue that is outside of the uterine cavity that can scar the tubes, can cause chronic pelvic pain, and if it's scarring the tubes, then again, those are patients that are oftentimes, especially if it affects both tubes, those are patients that may require more aggressive therapy where we're bypassing the tubes with in vitro fertilization to be able to conceive. Also, in terms of the marijuana, there's really not a whole lot of data looking at women in pregnancy and marijuana. We do know that, women who smoke marijuana during their pregnancies may have smaller babies. We know also that men who smoke marijuana have lower motility counts than their non-smoking counterparts. So generally, if I do a consultation and I find that, okay, well, my partner smokes marijuana, I smoke marijuana sometimes, because there's not a whole lot of data, I would recommend that we work on cessation, because we really want to try to optimize the environment for pregnancy. We know it can affect pregnancy. There may be other negative, there may be other things that are negatively impacted by, smoking marijuana. So I usually will say, let's refrain, let's work on getting pregnant, especially as it relates to the sperm.
Thank you. We have next here. My cycle has gone from 28 days to an average 25 to 26 days. Does that mean I'm perimenopausal?
Not necessarily. Our cycles do tend to change a little bit. I mean, this change would not necessarily concern me. what I would recommend if you are somebody who's childbearing age or desires pregnancy, go and have your ovarian reserve assessed. The simplest way to do that is to get your AMH drawn. AMH stands for anti-Müllerian hormone level. What this is a hormone that's produced from the cells that support the resting eggs in your ovary. So the higher AMH is, the more reflective it is of a good number of eggs in your personal egg bank. And so that's a good way to spot check, okay, what's going on? Again, don't forget, age is going to impact your ability to conceive ultimately. But changes like this in your cycle don't automatically make me feel like there's something wrong with, your ovarian reserve or that you're near menopause. It's common for our cycles to change a little bit over time as we get older. But this wouldn't be a concerning change to me. In the absence of other information, like, the AMH was low in this case.
Next. At one point, I was told that I had a bulky uterus. What exactly does that mean?
So that makes me think of either things such as fibroids that might be, sometimes we as physicians will, describe a uterus as being bulky because there are multiple fibroids that are in the muscle of the uterus. Again, what I would recommend is, again, this whole discussion is, allowing us to understand things that we may need to follow up on in terms of our own reproductive and general health. And so I would say, if they said bulky uterus, the question is, are there fibroids there that are causing the uterus to be bulky? Again, where are these fibroids? If you're interested in achieving a pregnancy, is going to be important to find out. Also, there is something called adenomyosis, which is essentially endometriosis that affects the muscle of the uterus. Okay, so we talked about endometriosis, which is basically endometrial tissue outside of the uterus that can cause inflammation of the tubes, can cause chronic pelvic pain, can cause infertility. Also, we can have, essentially with adenomyosis, what this is endometrial tissue that has, endometrial tissue really should be limited to the lining of the uterus. Okay, with adenomyosis, you have endometrial tissue that kind of percolates in between the muscle of the uterus and can cause the uterus to look bulky. Even though there aren't discrete abnormalities such as fibroids, it can cause the muscle to look thick. And those patients with adenomyosis may have chronic pelvic pain in the same way that patients with endometriosis have. So I would encourage you to go back to your doctor and ask questions. What do you mean my uterus is bulky? What do you see when you do an ultrasound? Are there fibroids? Where are they? Especially if you're wanting to preserve your ability to have children in the future.
Why are so many African American women suffering from infertility issues such as fibroids, PCOS, and endometriosis?
That, if, again, that's another one of those, if I could understand the why of it, I would have made my contribution to reproductive medicine. The reality is that African American women are twice as likely to suffer from infertility than their Caucasian counterparts. And it is because we struggle with fibroids, PCOS, endometriosis, and other things that can impact our fallopian tubes and our fertility. Also, medical problems, such as obesity or other hypertension or other issues that can ultimately impact, our ability to get pregnant and carry a pregnancy safely. I'm not sure why African American women have a higher fibroid burden, but it is true. PCOS, again, I think, I want to go back to that question, like, how can I treat my PCOS? Part of this is, doing a good job managing your weight. Just because we are more insulin resistant when we carry around more weight. So weight loss also can kind of help to mitigate some of those symptoms associated with PCOS. Again, more weight loss, less insulin resistance, and therefore a more normal hormonal environment. So again, addressing some of the issues with obesity in our community may help to sort of lower some of the incidence of PCOS or some of the poorer outcomes related to PCOS. Fibroids, I have no idea why why we're challenged in the way that we are with having a much higher fibroid burden than any other group of women.
Along the conversation with fibroids, here's a question from someone who has 2 uterine fibroids. She says the largest of them is 6 centimeters per her last doctor's visit. She is 30 years old and wants to know what options does she have to either shrink the fibroids or rid her body of them completely, and how do they affect her chances of getting pregnant?
Yeah, so kind of going back to what I said before, understanding where that fibroid is going to be important. Also, is it pushing up on a fallopian tube or causing distortion of the anatomy that's ultimately going to affect your ability to get pregnant? When I think of a fibroid pushing into the cavity, I know that that's going to impact implantation as well. And so understanding where these fibroids are, I would recommend that if you're wanting to conceive, that you seek out a fertility specialist so that we can understand where the fibroids are, what's going on with your fallopian tubes, and what things look like globally so that we can optimize the environment for pregnancy going in. If that fibroid is pushing into the cavity, then again, my recommendation would be surgical excision to remove that fibroid from impinging on the cavity and lowering the odds of implantation there. Again, you want to steer away from things like uterine fibroid embolization or other things that can impact the lining of the uterus. Also, we know that when they do those embolizations, sometimes the material that they use to embolize the vessels can end up in the ovarian vessels and cause decreased blood flow to the ovaries and diminish ovarian reserve over time, diminish number of eggs over time. So, again, I think seeking out a specialist who can help you navigate how to identify where the fibroids are and how to address them safely so that we keep that environment optimal for pregnancy, I think is going to be important for you.
Next question. I am 45 years old and do not have any kids. I just ended a 10-year relationship and I thought I would have kids by now. What are the steps that I should take if I am interested in preserving my eggs?
So again, seeking out an infertility specialist to help you kind of identify what your ovarian reserve is, and also any other barriers to conception. At 45, we know that, most women have some evidence of diminished number of eggs. As I mentioned before, at 45, we know probably about 90% of the eggs are likely to be chromosomally abnormal. So, we would need to sit down and look at all of your data and understand, okay, how many eggs do you have? What are the expectations of being able to get eggs from treatment or be able to achieve a pregnancy? I do know that, at 45, generally the most efficient path to pregnancy may be through the use of things like egg donation, just because that's efficient. But I think sitting down and talking to a fertility specialist so that you truly understand what the picture looks like for you so that you can come up with a tailored plan of treatment.
Let's see here. Have you noticed a high physician referral rate of hysterectomies for women of color? Also, have you noticed a high incidence of invasive surgical procedures for the removal of fibroids in women of color? And finally, what is your opinion of the Lupron medication to treat fibroids?
Yeah, no, as a fertility specialist, I don't do hysterectomies at all. I'm usually in the business of trying to preserve and optimize the uterine cavity for pregnancy. So I definitely don't see that. I did run across an article recently this week that that discussed the fact that women of color are more likely to have uterine sparing surgeries to treat things like fibroids or other issues rather than undergo a hysterectomy for symptomatic fibroids. So that information is out there. I think that if the fibroids are symptomatic or they're causing bleeding or severe anemia, then that's obvious that they need to be addressed. Also, if they are fibroids that are pushing into the cavity, then again, that is going to require surgical intervention to optimize the cavity for pregnancy. So those are legit reasons for an invasive surgery to remove fibroids. But other than that, if they're not causing symptoms, they're not impacting your fertility, then generally we just leave them alone. If they're sitting in the muscle outside of the cavity and it's small, 3 centimeters, 4 centimeters, I would leave it alone. It's not going to impact implantation. In terms of the last question about Lupron, again, if the fibroid is inside the cavity and it's in an area where it's going to impact implantation, even if you shrink it, it's still in the cavity, for the most part. But I don't mind trying to use those kind of medical interventions to try to help with symptoms, particularly if it helps you avoid a surgery that you may not really need if you're not symptomatic and you're not trying to get pregnant.
Several questions around the flow, heavy flow for menstrual cycles. Do birth control help with the flow?
Yes. So it can decrease if you're somebody who has heavy cycles, it can help to decrease your menstrual flow each month. What I would recommend, though, again, if somebody's trying to get pregnant, that we evaluate the cavity again through that saline infusion ultrasound to make sure that there are no polyps or fibroids that might be causing the heavy cycles, because then you want to address the source of that. And again, if it's just polyps or fibroids that are limited to the inside of the uterine cavity, those can be removed through an outpatient procedure, very well tolerated, no incisions involved. So I think, if you're experiencing heavy cycles, I would want to rule out pathology inside of the cavity. But definitely if there's no pathology and you're just experiencing heavy cycles, birth control pills can help with, patients that have severe pain during their cycles or heavy flow. It can help with both of those.
Okay, I am going to take just one last question that came through our private text. This listener has been dealing with fibroids for about 10 years, and she explains that she has gone through several prescribed medications and 7 procedures to remove them, including cesarean, Da Vinci, laparoscopic, and hysteroscopic. She said they led to increased blood loss and caused severe anemia, resulting in multiple IV infusions. In the latest assessment, she was instructed, or I guess suggested, to have a hysterectomy because another surgical removal of fibroids would completely destroy the integrity of the uterus. So everything has been very challenging for someone to cope with, as she is 45 with no children. Her Follicles are great and the tubes are open. So she would like to know, if the body is constantly regenerating cells, is there a possibility that through a change in diet and or socio-emotional factors that the uterus might heal itself to create a habitable environment for an egg to implant itself?
I am so sorry for everything that caller has been through. That sounds awful. I think that, it really does sound like we've tried not just multiple times, but I think she mentioned that there were 6 different surgeries to spare her uterus and attempt to remove fibroids. I'm nervous that doing another surgery may not be fruitful for her, just given where we've been. Also, I wish that there was something I could give to kind of help treat fibroids naturally or help them just to go away on their own. But when a patient describes that many surgical procedures and regrowth of fibroids, I think it would be hard to really recommend any other intervention right now besides hysterectomy, potential, especially if there's an issue with severe anemia and needing blood transfusions, and this is kind of getting to the point where it's life threatening, maybe life threatening to her. These are the scenarios where oftentimes we will start discussing things like surrogacy, and trying to find a way and craft a plan, a tailored plan that's more likely to be successful to help with patients being able to build their families, even in the setting of some of these really very, very sad challenges where we're doing multiple surgeries and we're still not able to resolve the issue.
Well, thank you so much, Dr. Bess. This has definitely been an informative conversation. As you see, we had a ton of questions
Yes.
from our audience, and this was just over a few days. As you know, at first you and I were just going to talk, between the two of us, but I'm so happy that we were able to record this and invite others in to listen so they could hear from you and also get their questions answered. We definitely have to plan a series. I think that there's, of course, a lot more to be shared and for us all to learn as we go through life, from our menstrual cycle to menopause.
Exactly. I would love that. I'm happy to come back anytime and, talk about my own personal experiences. As you know, I've got, I struggled with infertility, and, I have been, in many of my patients' shoes before, and, I have an IVF baby from this process. And so, I've had my own struggles. So I'd love to come back and talk and answer any questions your viewership, has on this topic and empowering themselves to take charge of their reproductive life and reach their reproductive goals.
Oh, that would be awesome. I think what I will do is ask for more questions so we can plan our second conversation and address the questions that come in. And of course, hear your personal journey and story. I think that is very empowering. Again, you were very helpful and continue to be, such a supportive friend and counselor and expert, from Monica to Dr. Bess in my world. As I said earlier this evening, I was quite naive. Luckily, there are some positive things that we saw with just the health and overall situation that I am in, but it's something that I definitely could have taken charge of, earlier. to make sure that we are going to have success. Thank you again, Dr. Bess. Thoroughly enjoyed this conversation.
Thank you for having me. It was a pleasure being with you this evening.
And I can't let you go just yet, though. You know, we have some fun stuff we have to do at the end of every conversation.
Okay.
Okay, so we'll get started. My favorite place in Ann Arbor is...
Oh, Pizza House.
Pizza House. Mine too. Okay. Ladies, the health and beauty product that you must keep is...
Mascara.
Oh, I so agree with you.
Yes.
And finally, I know that Atlanta is known for rap, but my favorite Nelly song is...
Oh my gosh, it's hot in here. Her. It's hot her.
That's right. Tell us how we're supposed to say it. Thank you again, Monica. Always fun to see you. And I am so grateful that you were able to share in this way with SHEMAKERS and our listeners this evening. Before I let you go, is there one final note that you would like everyone to make sure that they have in their playbook regarding women's health and family planning?
You know, just take charge, gather all the information you need. If you know that you want to have a family one day, you know, come just sit down and talk to somebody like me. Let's assess your situation and figure out what our strategy is going to be moving forward.
Awesome. And how is your little one?
She's great. She's great. Sassy. That is great.
When are you going to make it back to Ann Arbor?
Hopefully soon. I need some more Michigan gear. You know, I need some new like sweatpants, and I need to go to all my little stops. I told you like Pizza House is my favorite, but that's like, it's a close tie between that and Stucci's ice cream. So, you know, just got to go hit up all my little spots and, you know, live in the nostalgia for a little bit.
Exactly. I think back like, was it really 20 years ago?
Don't say that. It was not, I don't know. My lips don't know how to say 20 years.
You see, I kind of trailed off.
Yeah.
Yes.
Oh my gosh.
Good to see you. And we'll get our walk and talk in soon.
Awesome. I'm ready whenever you are.
Have a good evening.
You too.
Well, everyone, thank you again for joining me for this special conversation with Dr. Bess. I really enjoyed it and hope you all got answers to your questions. You heard it here. We are going to continue this dialogue. So much more for us to discuss around women's health, and especially as it relates to pregnancy and fertility, as well as infertility. I learned so much this evening, and I hope that you all were taking notes. Please, you heard us. We want to make sure that you get all the information you need to make good decisions and advocate for your health. So follow up and email us questions that you have, and we will make sure to get them answered and prepare for our next discussion on women's health. Remember, we are on social media, and you all can connect with us anytime, not just on Wednesdays. We are at Heelsand Helmets on Twitter, Facebook, LinkedIn, and Instagram. So be sure to follow us there. Can't believe we are wrapping up another month. As we close out April, we're getting ready to celebrate our mothers. So next month is going to be all about mothers and motherhood, including a conversation with my own mother. And I am so looking forward to that. So save the dates. You know, we are live on Wednesdays for SHEMAKERS. Thank you so much for listening, and be sure to share this information. The show will be up live on Facebook and YouTube. So share it on your pages, invite others to join us. As you see, we are making sure that you're empowered to to live your best life. So until the next episode, remember, you are a she maker, and I am here to help you make big plays, get in the end zone, and win. Have a good night. Thank you for watching.